Hi everyone. Today we're going to talk about headaches, and almost everyone has had a headache at some time in your life. And some headaches are related to colds, allergies, or stress. They can be temporary, some can be very serious and potentially life-threatening, especially if it's a secondary headache, such as the headache is being caused by an aneurysm, a bleed, or a brain tumor. As part of your nursing assessment, it's very important that you ask patients about the patterns of their headaches. For example, when did the headache occur? How often? How long do they last? Do certain foods, alcohol, or other things trigger the headache? Have there been any recent changes in your headache? How do you treat the headache, and does this treatment work? How often, and what drug or herbal type remedies do you take? Some other questions that you can ask: is there a family history of headaches? Where do the headaches begin? Do they spread to other areas? Do you experience other symptoms with the headache, such as weakness or changes in speech? And how does the headache impact your activities of daily life? It's very important to encourage patients to keep a headache diary, which may help identify the type of headache that they're experiencing. Teach them to notify their healthcare provider if the quality, the intensity, or nature of the headache increases or it changes. Encourage them to report whether the headache is associated with unusual visual changes and whether the prescribed drug is effective or is no longer effective. Headaches are thought to be a neurovascular disease, maybe a primary or a secondary symptom, like I said before. The different types are vascular headaches, migraine headaches, cluster headaches, and tension headaches. For our purposes, we're going to be talking about the migraine headache. This is just a little clip on vascular headaches, thought to be painful swelling of the blood vessels, and we're going to concentrate on our migraines. Migraine headache, which is a chronic episodic disorder with multiple subtypes. It's characterized by intense pain on one side of the head, unilateral, worsening with movement, and occurs with either photophobia or phonophobia. One is sensitivity to light, and phonophobia is sensitivity to noise. And you can either have moderate to severe nausea or vomiting can be present. Migraines tend to be familial, and women usually are affected more commonly than men. Migraine sufferers are also at a risk for stroke and for epilepsy. The cause of migraine headaches is likely a combination of a vascular type problem. It could be genetic as well, neurologic, hormonal, and environmental factors that can cause migraines. It's basically the blood vessels in the brain, they overreact to a triggering event. They cause spasming in the arteries at the base of the brain. And this response is followed by an arterial constriction and a decrease in cerebral blood flow, which cerebral hypoxia then may occur. Platelets clump together and serotonin, which is a vasoconstrictor, is released. Other arteries in the brain dilate, which triggers the release of the prostaglandins, which are the chemicals that cause inflammation and swelling, and other substances that increase sensitivity to pain. So it's kind of a snowball effect with the migraine, and how it works in the brain, from vasodilation to vasoconstriction, causing the prostaglandins to produce inflammation and swelling, which then causes that headache really, really bad. So these are the signs and symptoms on this slide, which I've gone over a little bit here. The severe throbbing, usually on one side of the head, and the nausea, vomiting, dizziness, sensitivity to light, and also not just the photophobia, but also the phonophobia. The migraine, there's different phases of the migraines. There's the prodrome phase, in which the patient has specific symptoms, such as maybe some food cravings or any kind of mood changes. The aura phase, if present, because there's migraine with aura, migraine without aura. If the migraine phase, the aura phase is present, usually, which generally involves the visual changes, flashing lights, or diplopia, which is your double vision. They also can experience numbness or tingling, drowsiness, dizziness. The next phase is the headache phase, which can last a few hours to a few days. The termination phase, in which the intensity of the headache decreases, and then the prodromal phase, in which the patient is often fatigued, maybe irritable, and has muscle pain at that time. Diagnosing migraine headache is based on the patient's history and on physical, their neurological, and psychological assessment. The typical migraine, as we said before, is unilateral, one-sided. It's usually frontal temporal area. They have throbbing pain in the head that is often worse behind one eye or one ear. It's often accompanied by a sensitivity of their scalp, anorexia, as we said before, photophobia, phonophobia, with nausea with or without vomiting. The pain and the associated symptoms can last from 4 to 72 hours. If the patient presents with any other kind of neurological problem beside the subjective data and maybe some positive neurological findings on exam, we'll go ahead and order an MRI to see if, especially if they have those other symptoms, as well as if they've had seizures that's not consistent with a migraine, or a change in the severity of the symptoms or frequency of the attacks. We definitely will do an MRI or some kind of neuroimaging if the patient is 50 years of age or older with a new onset of headache, especially in women. Women with a history of migraines with visual symptoms may have an increased risk for stroke. The risk increases if a migraine with visual symptoms occurred, especially in the past year. It's always important to tell patients with migraine to notify their healthcare provider if they experience any symptoms such as facial drooping, arm weakness, or difficulties with their speech. So some interventions for headaches. First of all, they're kind of classified in two different areas. One is called abortive therapy, and that's aimed at alleviating pain during the aura phase, if present, or soon after the headache is started. In general, the patient is started on a low dose of the medication that is increased until the desired clinical effect is obtained. It's usually prescribed to manage migraine headaches. Some of the drugs being used have some major side effects, contraindications, and some nursing implications, so you have to be really, really careful when you start patients on abortive therapy. Some of the mild migraines can be relieved by acetaminophen, Tylenol. NSAIDs such as ibuprofen, Motrin, naproxen may also be prescribed. There are some over-the-counter anti-inflammatory drugs for migraines. Includes Advil, migraine capsules, Motrin, migraine pain caplets, Excedrin, migraine tablets. And those all contain, Tylenol, aspirin, and caffeine. Caffeine kind of narrows the blood vessels by blocking adenosine, which dilates vessels and increases inflammation. If there's nausea and vomiting, antiemetics can be prescribed. Reglan may be administered with NSAIDs to promote gastric emptying and decrease vomiting. But you have to be really careful with Reglan because you can only give it for a certain amount of time, and especially on a regular basis, but it wouldn't necessarily be regular basis with a migraine. But we have to really watch Reglan too for seizure activity, so we have to be really careful when giving Reglan. For some more severe migraines, we use drugs such as the triptans preparations, the ergotamine derivatives, and a combination of the isomethatines. A potential side effect of these drugs is that rebound headache, so we have to be really careful with those drugs. The triptan preparations relieve the headache and associated symptoms by activating the serotonin receptors on the cranial arteries, the basal artery, and the blood vessels to produce a vasoconstrictive effect. Some examples are salmetriptan, elatriptan, sumatriptan, which is also called Imitrex. You may be more familiar with that. It's also available in tablets, as an injection, or in a nasal spray. They're highly effective for pain, nausea, vomiting, and light and sound sensitivity with very few side effects. Most are contraindicated. This is the scary part about these drugs. Contraindicated with actual or suspected ischemic heart disease, cerebral vascular ischemia, hypertension, peripheral vascular disease, and those with Prinzmetal's angina because of the potential for coronary vasospasms. Make sure that you teach patients, especially with the triptans, to take them as soon as the migraine develops. If the patients instruct the patients to report any chest pain or tightness to their healthcare provider immediately. And some expected common side effects may happen is flushing, tingling, and a hot sensation. They usually subside after the body gets used to the drug. And make sure that you don't take any triptan drugs with SSRIs or St. John's wort, and those are both commonly used for depression. Your ergotamine preparations such as Cafragot are taken also. They're abortive type medications at the start of the headache. Midrin is a combination drug that can also be taken. Opioids and barbiturates are not recommended for patients because of the addictive ability, and some opiates actually cause a migraine. Our preventative drugs and other strategies are also used, especially if the headache occurs more than twice a week, if it interferes with ADLs, or it's not relieved with acute treatment. So the physician may initially prescribe NSAIDs, also a beta blocker, calcium channel blocker, or an anti-seizure drug. Propranolol, which is Inderal, Novopranolol are the only beta drugs, beta blockers that are approved for migraine prevention. And basically they lower blood pressure and decrease pulse rate, which means that we don't have as much blood, so we can vasoconstrict instead of vasodilate. Verapamil is a calcium channel blocker that may also be used for some patients. Topamax is one of the most common anti-epileptic type drug used for migraines. Make sure that you check for reports of suicide, because it does have warnings about that, and especially with the patients that have bipolar disorder. In addition to drug therapy, there's trigger avoidances and management are important interventions for preventing migraine episodes. The tyramine-containing products, such as pickled products, caffeine, beer, wine, preservatives, and artificial sweeteners. Excuse me, such as these types of foods may reduce their headaches. Sometimes at the beginning of a migraine attack, the patient may be able to just reduce pain by lying down and darkening the room, and if the patient falls asleep, they should remain asleep. Some patients also use yoga, meditation, massage, exercise, and biofeedback are very helpful in preventing or treating migraines. Your chart on page 931, it's a patient and family education preparing for self-management. Gives you some ideas on what the patient can do for themselves, what foods to avoid, what are some factors of drugs that may precipitate a migraine attack, and just some other non-pharmacological factors. On table 44-1, some commonly used drugs for migraines, it kind of goes over the ones I just went over in this little lecture, about the triptans, the anti-epileptic, Depakote, Topamax, the triptans, Zomig, Imitrex, Relpax, then your beta blockers, propranolol and timolol, and your ibuprofen. Some of the Cafergot is probably the best known ergotamine preparation that they have. Okay, so that ends our migraine headaches. I'll do the next on cluster.